We identify high-risk patients for neoadjuvant treatment with the staging techniques we talked about, endoscopic ultrasound, the most important, making sure we have CT and PET scans to rule out metastatic disease. Occasionally we do understage patients. We think we have an early T1 or T2 stage tumor and gastric cancer, let's say the pathology comes back T3N1, so that is a high-risk patient. Then we extrapolate from Asian data where there's clear evidence in gastric cancer from thousands of patients treated with D2 gastrectomy. That 6 months to a year of adjuvant chemotherapy also improves survival. So in a patient that's undergone upfront surgery, as long as they've had a good resection, D2 resection with negative margins, if they're node positive, occasionally T3, we would treat T3N0. We would consider adjuvant chemotherapy, which translates into very similar survival benefits that we see with perioperative chemotherapy. If you look across the board, the risk reduction is about a 25 to 30% reduction in the risk of recurrence, which typically translates into about a 10 to 15% survival benefit at 5 years. So if a patient's had upfront surgery, we would consider adjuvant chemotherapy. The exception would be, as I said, in the American trial in gastric cancer where the quality of surgery was poor, low lymph node retrieval. That patient, if they have positive nodes and the surgeon retrieved less than 10 to 15 nodes, then I might consider the addition of postoperative radiation. Now for esophagus and GE junction cancers, it's very hard to give postoperative radiation. The field is huge and it's poorly tolerated. So if we have an understaged esophagus GE junction tumor that's T3 or node positive, if the surgery was appropriate and margins were negative, we might also consider adjuvant chemotherapy. But that's a rare patient. We advocate for neoadjuvant preoperative treatment in these patients if possible. Better tolerated, and we get survival benefits.
With the advent of a perioperative chemotherapy being the standard of care, most of our patients who have a disease beyond T3 or nodal positivity should definitely be getting perioperative chemotherapy upfront. We all know we occasionally come across patients who've had surgery upfront. So what do we do for those patients? The standard approach is based on the 0110 study, which was a US intergroup trial from years ago, which has validated that adjuvant chemoradiation is the standard of care in these patients. The only difference is that we don't use the bolus 5-FU as it was used concurrently with the radiation in the original arm. I tend to change it to an infusional 5-FU arm with the radiation and then give 5-FU cycles before the chemorads is started and then after the chemorads is completed. What's interesting is that data really showed that patients who had inadequate surgery, less than a D2 dissection, were the ones who benefited with the radiation in the, that was the reason that the radiation worked and helped them in that adjuvant arm. But with our patients getting better surgery, better D2 dissection, the question is, what is the role of radiation in these patients? And I tend to resort to the perioperative chemotherapy as a standard, in which case patients get, because we have a multidisciplinary clinic, we discuss the patients up front. They don't go to surgery generally if they have T3 or higher disease. And so we give them chemotherapy before and after. If for some reason they've had a D1 or lower level of dissection, those patients we tend to address adjuvant radiation for.